Okay, so this is Care of the Patient with Burns, chapter 26 in your text. I put the objectives on here. The objectives are listed on your concept outline. Just wanted you to be clear of exactly what our focus is. I do go into the types of burns and different things in it because this will help you figure out or understand principles of infection prevention and how to prioritize and determine appropriate care needed for that patient. Just some facts concerning burns, where most burns occur in the home. Close to 45,000 hospital admissions every year. There are 2.4 million people a year suffer from a burn, some sort of burns, and there are estimated 700,000 emergency room visits per year due to burns. Between 8 and 12,000 burn patients die on an annual basis, and about 1 million have some type of permanent disability. Of course, age, health, other things, depth of injury, where they were injured, all is a factor. Children under the age of 4 are more at risk, and males are twice as likely to suffer from a burn injury than a female. All burn injuries are painful. And some results just I put on there: the skin integrity, fluid and electrolyte loss, risk of infection, body temperature, all affected by damage to the skin integrity. And thinking about how many burns occur in the home, there goes the nursing and teaching. Things that we can teach on is about cigarette smoking. Careless cigarette smoking is a leading cause of house fires. And absent or non-functioning smoke detectors. Having a functioning smoke detector decreases the risk of death by 60%. In this area, you'll see a lot of use of wood stoves, which is another risk. Where in the wintertime now, there's exposed heating sources, electrical cords that can catch a fire, unsafe storage of flammable or caustic materials, water heaters set above 120 degrees, removing containers from a microwave and the container is hot without using a pot holder. Some of the older housing in the area, and substance abuse, any type of alcohol or illegal drugs, mental impairment can increase the risk of a burn injury. Slide 4, mechanism of injury is just 4 types of thermal, electrical, chemical, radiation. Some types of thermal, like flame, could be a dry heat. A moist or liquid can lead to a scalding. Objects or hot surfaces lead to a contact thermal injury. Of course, you can also have a thermal injury contact from tar or grease. Some types of electrical, figure 26.8 in your text. I'm trying to find it here. If you have the 8th edition, it's on page 471. It was just a good picture demonstrating electrical injury. The electrical current enters the body, and the surface injury may be very, very small. Meanwhile, there is extensive internal burn injury. Chemicals, acid, alkali, organic. There's lots of materials in a household that contain these ingredients. Some alkalis are found in oven cleaners and fertilizers. Some examples of acids are the multiple cleaners around the house. Radiation, ultraviolet, that's from sunlight, like a sunburn. X-rays can do it. People being exposed to radioactive materials, sometimes for radiation therapy, but the more serious exposure to radioactive material burns are usually due to industrial accidents. Wow, I don't know what happened to this slide. It's supposed to be the size of a burn, depth of the burn, age of the victim, body part involved, mechanism of injury, history of cardiac, pulmonary, renal, or hepatic disease, injuries sustained at the time of the burn. When you think of the respiratory, there could be direct airway injury, carbon monoxide poisoning, thermal injury, smoke poisoning, facial edema. The burns affect the respiratory, CV, gastrointestinal, metabolic, immune, renal, every body system. Oh, I see. I didn't realize. I don't know why this slide's coming in this way. Okay, so there's everything. Okay. Slide 6, table 26, 1 and 2 are in your text on page 466 and 467. And any page reference I given is going to be in the 8th edition, which I have in front of me. Anyway, this is a different picture than what's in your text. I just liked this, but I thought those two tables did a really good job. It's just, being very aware of the difference so you understand how to manage burns. So a first degree burn damages only the outer layer of the skin or the epidermis. It is very, very superficial right here, just the epidermis. There will be pain, redness, mild swelling or edema, and in a couple of days there's peeling or desquamation. Second degree burns are partial thickness, and it damages the outer layer and the layer underneath, so it damages the epidermis in different degrees of the dermis. We'll get into that a little more. Third degree burn is a full thickness. It destroys the entire epidermis and dermis, and there are absolutely no skin cells surviving or nothing to regenerate. Okay, so slide 7. This is one of the, well, let me stop a minute. Okay, so when I talked about the partial thickness burn, this is talking about second degree burns. There can be a partial thickness and a deep thickness, so there's different levels of it. On this one, the superficial or partial thickness second degree burn usually has this pink, moist, there is some blood supply. There is blistering due to cell and protein breakdown, and it involves the upper third of the dermis. So, of the dermis. The epidermis is gone, the upper third of the dermis. Now, a deep partial thickness, usually there is no blistering. You just see that shiny appearance. There's decreased blood flow. It will result in scarring. Very painful because the nerve endings are exposed, and it can result in fluid and electrolyte loss. And because of the swelling, the damage, possible infection, it can go deeper and end up being a third degree burn. This is the full thickness. Total destruction of the epidermis and dermis. It's dry, hard, leathery, waxy looking. It forms an eschar, which is the dead tissue. Severe edema. It can be anything from white, yellow, deep red, brown, or even black. The deepest full thickness, the deep 3rd degree burn, can go right through the muscle and sometimes even to the bone. When you're doing a skin assessment, you are assessing the size of the burn, the depth of it, also the location has a lot to do with the percentage of the total body surface area that's affected, and use the rule of 9s, which you've probably heard in the past. We're just briefly going over. It's the rule of 9s, multiple 9% of the body. The next slide is a picture. Here you go on how to figure out the rule of 9s. And you notice on a child or infant, the head is 18% because it's a comparison of the body surface area compared to 9% on the adult. Let's see, arms are 8%. There's not, 9%. Perineum on the child is added in. The legs are smaller, the head is bigger. Just put some parameters out here just for your information. Vascular changes. Lots of vascular changes go on. Blood pressure falls because fluid is leaking out into the intra, outside of the vascular, to the interstitial fluid. You're losing sodium and protein. The blood vessels are damaged, that's why the circulation is affected, leading to low blood pressure. There's hypovolemia. Tachycardia is a compensatory. I mentioned impaired blood flow. The blood vessels begin to constrict, and the fluid is leaking out and shifting. That leads to a capillary leaking, or what's often referred to as third spacing. The loss of the fluid and electrolytes leads to drops in protein. The loss of volume leads to a decrease in the cardiac output, and of course all of this leads to impaired tissue perfusion. This third spacing or fluid shift usually begins within the first 12 hours and might last up to 36 hours. There is a profound imbalance of fluid, electrolytes, acid-base balance. They lead to hyperkalemia, elevated potassium, a low sodium, hemo concentration. So your hemoglobin hematocrit initially look elevated because it's so concentrated, but as you add volume and replace it, it shifts and they end up being low. The hyperkalemia or elevated potassium is due to cell destruction. So the potassium that was in the cells now goes outside of the cells, is released from the cells, leading to potassium in the bloodstream. And the hyponatremia is, again, the fluid shifts and the fluid loss, and that leads to a loss of sodium. There are several stages with the vascular change. So first, the fluids, after 24 hours, the fluids try to remobilize. And then 48 to 72 hours after injury is the diuretic phase, where the body's shifting off the excess fluids. And that can lead to low potassium, low sodium, or hyponatremia and hypokalemia. Cardiovascular, again, I just had that follow right behind the vascular. Hypovolemic shock is a common cause of death early and after any serious injury, especially burns, so that is what you're watching for. We will study shock much more later, just getting an idea of what you're looking for a burn patient in this chapter. They can have a metabolic acidosis. The tissue damage results in a release, I mentioned the potassium and the sodium before. cardiac rhythm needs to be really watched, especially electrical burn, but cardiac arrhythmias can occur with the electrolyte imbalance. Pulmonary changes. I put on here, simple things where direct inhalation injury or systemic response, the cilia in your lungs is damaged, there's airway inflammation, nothing is functioning right, can't clear the mucus, pulmonary edema occurs because the fluid is escaping, there can be airway obstruction. The pulmonary edema does not necessarily result from direct damage. It is a result of this fluid overload, or the fluid overload, the fluid shifts. Also, there's a histamine release, or it's your body's inflammatory mediators are released, and it leads to a leaking of the capillaries and flow of fluid into the pulmonary tissue space. I have a couple of pictures. The first one just showing the different places that they can have burn from inhalation or damage in the respiratory tract from inhalation. And then this picture just showing the consequences of fluid overload in the lung. You may want to look at this and get a good idea of what is going on with, here's the inflammatory response, and it causes the leaking and the accumulation of fluid in the alveoli. So the compliance of the lung is less, the gas exchange is impaired, cyanosis, hypoxia, frothy blood tinged sputum from this fluid overload. Okay, so gastrointestinal assessment. The fluid shifting and decreased cardiac output leads to everything in the GI tract, in the gut, getting sluggish. More than 20% of people, if burns of greater than 20% of the body lead to a decrease or halting in peristalsis, which leads to gastric distension. All this increases the risk of aspiration. There's nausea and vomiting. This stresses can lead to this Curling's ulcer. The Curling's ulcer is an acute ulcer, usually occurs within 24 hours of the stress of a burn. It's an ulcer that occurs in the stomach, or it's the stomach or duodenum. You're looking for signs of bleeding or gastric ulcer, looking for hematemesis or blood in the vomit, or emesis or melena or blood in the stools. Occult, or it can be occult or non-occult. The patients are treated with H2 blockers such as cimetidine or ranitidine. They can be mucoprotectants or things like a blocker like omeprazole. And early enteral nutrition, if they're not being able to swallow well, but getting an NG tube or something, getting something in the gut to keep it from being empty. Sorry, that go on there. Cellular debris, the body's trying to get rid of it. Of course, when there's decreased vascular flow, it affects the kidney because there's decreased flow in the kidney. All the myoglobin that's being released. Later in other chapters, we'll get more into that myoglobin release from the muscle damage. They're large molecules, and it can lead to rhabdomyolysis. And this impairs the kidney and can lead to actually kidney shutdown. So you're monitoring the kidney function, BUN, creatinine, GFR, monitoring potassium, sodium levels. Very, very important. Urine color, odor, looking for particles. Why would you look for foam? Foam is present when there is protein. Protein molecules are too large to pass through the filter in your kidney, through the glomerular area. So if there's foam, that's damaged because large particles or protein is actually passing through, and there will be positive for protein in the urine. Important to monitor the urinary output in all burn patients, 1 for kidney function and 2 for their volume status. I found this picture. Your text actually has a figure 26-7. It's on page 471. It's a totally different image than this, but it gives you a rough idea of the body's response. I found this picture. I really liked it. I thought it was clear, talking about all the different things that are going on in the body. Okay. Slide 21. Believe it or not, we are almost there. Management of burns. The non-surgical, that doesn't mean they don't go to surgery, but things you're doing outside of surgical is, of course, IV fluids, monitoring responsive fluid therapy, drug therapy, mechanical debridement, enzymatic, different types of debridement. There's a chart 26-4. That's on page 475. No. Sorry about that. It's on page 479, fluid resuscitation of the burn patient. Not for memorization, just read over it, be familiar, because this is the kind of things I talked about on your objectives. What are you looking for? How do you manage the patient? This gives you a good idea of your assessments that you are doing on the patient. And I mentioned a few minutes ago, the urine output, it's an excellent indicator of the cardiac output and tissue perfusion. You want a minimum of 30 mLs per hour. You're monitoring the cardiac rhythm. You're looking for arrhythmias and problems with conduction. We'll get more into cardiac later this semester. Drug therapy, there's going to be analgesics, opioid and non-opioid. Often there will be antibiotics because the risk for infection is so tremendous. And different types of debridement, whether they do it surgically or with different kind of chemicals. Some key things on management of burn patients is avoid intramuscular or subcutaneous injections. The absorption through the soft tissue is unreliable because their volume status is so low and they have so many fluid shifts, especially to the extracellular or third spacing. Avoid administering medications by the oral route because of the possibility of GI dysfunction, and make sure to medicate the patient prior to any painful procedure. This slide is just surgical management of burns. The first picture, escharotomy, full thickness to the chest. An escharotomy is a surgical procedure used to treat full thickness or third degree circumferential burns. Circumferential are ones that go around the entire circumference, around the body, around the limb, their whole circumference. In a full thickness burns, both the epidermis and dermis are destroyed and all the sensory nerves are gone also. There is a tough, leathery tissue remaining, and which was called the eschar, and escharotomy is where removal-otomy of the eschar or dead tissue. The next one is the fasciotomy. Fasciotomy is when somebody is severely burned and the fascia contracts down, so they have to go in and cut into the fascia to relieve the tension and pressure. It's something that we mentioned last semester in PEDS briefly when we talked about compartment syndrome, and that's something we will cover later this semester also. But it has to, that pressure from the fascia has to be relieved to prevent or relieve or unobstruct the blood flow from a compartment syndrome, or the circulation will be cut off to the area and result in amputation. The last picture is of a skin graft. I don't know if anybody's been in the OR and managed to see one, but this is the best picture I found on showing the skin being taken from a healthy area and placed or stapled onto the graft area. This slide is self-explanatory, dressing the burn wound. There's many different types of dressings that can be used. You don't need to memorize the types. No, sometimes there's various kinds. Sterile technique is imperative. Preventive infection is imperative with any care of burns. Resuscitation is 3 phases. The resuscitation or early phase, the acute phase, and then the last is the rehabilitation phase when you deal with burns. So this is continuous for no set time, usually 24 to 48 hours. It's until they start to diurese. Remember I said earlier, when the body, they're so hypovolemic, and then it shifts and they start to diurese. And assessment of body systems, goal of management: secure the airway, support circulation, fluid replacement, prevent infection, maintain body temperature, provide emotional support. If you remember anything on burns, those are the key things for management of burns. During this resuscitation phase, early phase, some places call it the emergent phase. It begins at that time of injury. Some sources say it could be 72 hours at last. It says 24 to 48 in the text, but it can be as long as 72 hours. Number 1 goal is to prevent the hypovolemic shock, to replace fluid loss, and keep vital organs functioning. Vital organs: cardiac and pulmonary and renal. This phase begins, as it says, with resuscitation. It can be right on the site of when injury occurs with the emergency personnel there. It starts when you initiate fluids, and it ends when this tissue and capillary integrity is almost normal, and there is a decrease in the shifts from the large fluid loss. The amount of fluid you have to administer is based on the client's weight and extent of their injury. Most fluid replacement formulas are calculated from the time of injury and not from the time of arrival at the hospital. The goal is to prevent shock, as I mentioned earlier. Okay. The second phase, acute phase, can begin 36 to 48 hours after injury. It could be a little longer, but it's when after the resuscitation the person begins to diurese, fluid shift, stabilize on their fluid loss. When that's over, then they go into this acute phase, and it lasts until the wound is closure is complete. Your care still is focusing on their CV, respiratory, GI, nutrition, burn, the wound care, pain control, and you begin psychosocial interventions. The emphasis during this phase is on restorative therapy. You'll be focusing a lot on infection control, wound care, nutritional support, mentioned pain management, and of course physical therapy. Rehabilitative phase, that's the third and final phase. It begins with the wound closure and ends when their patient is at their highest possible level of function. goal of this phase is designed so that the client can gain as independence and achieve maximal function. It may last years, or it's like as I noted here, even a lifetime. Just some notations near the end of this presentation here on just fluid imbalances, what due to the fluid shift and the cell damage leading to low volume or hypovolemia can lead to metabolic acidosis, elevated potassium, low sodium, and the hemoconcentration that I mentioned due to the dehydration. One thing I remember seeing a lot with these type of traumas is you're giving them so much fluid volume and the hemoglobin hematocrit initially seems elevated, and as you replace those fluids you realize that their H&H is actually low. They don't always transfuse. I'm thinking sometimes they wait till they're about 8 or so, hemoglobin of like 8, and that would be hematocrit about 24. Not that you need to know those figures. Nutrition is another factor. It's essential to be able to have wound healing. The nothing by mouth is important until their gut is actually working. I mentioned in the beginning how it could be given through enteral feedings. And you want high protein, lots of carbs, because the metabolism is very, very elevated in burn recovery. Psychosocial preparation, that was one of your objectives. I just made some notes on here. Post-traumatic stress, sexual dysfunction, severe depression, disfigurement, changes in role and function, self-management, education, healthcare sources. They're in page 469? No, I think I wrote the wrong page. I did. It's page 489 in your text. On the bottom, evaluation outcomes. I thought that was really good. If you're talking care plans or thinking these are your goals that you would be reaching for. And that is the end of my presentation.